So this is your third OB lecture, and this is over nursing management during pregnancy. So the objectives of this lecture are prenatal care. We're just going to review the prenatal care guidelines, risk factors associated with adverse outcomes in pregnancy. We'll talk about history, identifying the components of an obstetrical history, fetal well-being. We'll be able to identify methods to determine fetal well-being, and then danger signs. So we'll list out the danger signs during pregnancy. So early prenatal care is crucial to the health of the woman and the unborn baby. The best strategy is for the woman to seek care before she conceives. The goal of prenatal care is to optimize the health of the woman and the fetus to increase the odds that the fetus will be born healthy to a healthy mother. So one thing we're going to talk about are teratogens, and those are any substance or process that can cause birth defects. The severity of the defects depends on when, during the development of the fetus, that it's exposed to the teratogens, and then also what particular teratogen they're exposed to. So exposure during the embryonic state produces the most damaging effects to the fetus. And so if you think about that, during that state, that's when all of the systems, the organ systems, are being developed within the fetus. So that's why it's the most crucial time frame. Teratogens usually fall into one of three categories: an ingested, infectious, or environmental substance. So examples of each: ingested, that's going to be things such as dilantin, chemo agents, tetracycline, and then alcohol and smoking. Infectious examples are going to be varicella, rubella, and cytomegalovirus. And then environmental are going to be things like radiation and mercury exposure. So your medications are classified in categories A, B, C, D, and X. So with that categorization, A and B typically mean no real risk involved. C means it's questionable. And then D, category D and X, they are proven that they do hold a risk to the fetus if they were to be taken during pregnancy. So those should be avoided, and then alternate drugs should be used if possible. So occasionally, category D may be given in spite of like the life-threatening situations, and that a lot of times it's going to look like a conversation between the patient and the practitioner. All pregnant women should avoid any medication without consulting their physician first. Other risk factors for adverse pregnancy outcomes are going to be like your isotretinoins. Some of you may have heard it referred to as Accutane, or your topical acne medications, alcohol misuse, anti-epileptic drugs, diabetes, folic acid deficiencies, hepatitis B, HIV and AIDS, hypothyroidism, maternal phenylketonuria, or sometimes you'll hear that shortened PKU. So with that, aspartame breaks down into phenylalanine, which does cross the placental barrier. A couple other things that make the list are going to be rubella, obesity, oral anticoagulants, STIs, and then smoking. So what that first prenatal visit looks like. Ideally, the first prenatal visit occurs as soon as the woman thinks she may be pregnant. Usually when the woman has missed a period or is late for a monthly period, that typically kind of triggers that first visit. The first prenatal visit is usually the longest because of obtaining the baseline data from which all the other subsequent visits are going to be based off of. The history is one of the most important elements of the first prenatal visits. During the first prenatal visit, all of these things will be done, and then we'll go over that in more detail with the next slide. So you will obtain an obstetrical history. So you'll hear us refer to gravid, which means the state of being pregnant. Gravida refers to the pregnant woman, specifically the number of pregnancies. Para means the number of deliveries at 20 weeks or greater. A nulli gravida is a woman who has never experienced pregnancy. A prima gravida is a woman who's pregnant for the first time. Multigravida is a woman pregnant more than one time. So we'll talk about a system that we use to obtain that obstetrical history. It is called the GTPAL system. So within that, the G stands for gravida, or the number of pregnancies. T stands for term deliveries. So these are going to be deliveries between 38 and 42 weeks gestation. The P stands for preterm deliveries, the number of pregnancies ending greater than 20 weeks or viability, but before the completion of the 37th week. A stands for abortion, which is the loss of pregnancy before 20 weeks or viability. And then L stands for living children. So that is the number of children who are currently living. So then the medical surgical history. You would want to record any major medical problems such as heart disease or diabetes that will require closer surveillance. Prenatal records should also list all medications the woman is taking, including over-the-counter medications and herbal remedies. Risk factors for any infectious disease. You'll determine the woman's immunization status and then determine the risk factors for HIV and AIDS. Additionally, you will take a family history. That is important because it may highlight the need for some genetic testing. And then ethnicity is also important due to some factors that can be carried based off of a person's race. An example of that would be sickle cell anemia, which is often carried in African Americans. And then you also want to take a social history. So this focuses on the environmental factors that may influence the pregnancy. Things such as social support, adequate housing and nutrition, alcohol, smoking, drug use, or exposure to those things. Additionally, a physical exam will be performed. Typically, it's performed by the practitioner, but the nurse may be present to assist, specifically in regards to like a pap smear. So it's important to teach in regards to having a pap smear performed on a pregnant patient. A normal side effect of having a pap smear is some small vaginal bleeding. So you need to mention this with your pregnant patients, that it's not uncommon for that to happen. You may, with some of your patients who have maybe had some missed pregnancies in the past, abortions, things like that, their anxiety might be a little heightened with this. So it's just important to relay that that is normal, but that anything in excessive amounts, they do need to report to their practitioner. A pelvic size and shape measurements may also be taken to make sure that the fetus is progressing as far as expected. So laboratory tests will also be taken as well. Typically, we'll do a serum pregnancy test just to verify that pregnancy is what's going on. CBC is done to check for things like anemia. Blood type and antibody screen is also checked for compatibility. Other tests for infections such as HIV, Hep B, and STIs may be performed. Rubella titer should be done, and then a urine screen to culture for bacteria may be performed. A pap smear, just like we talked about earlier, that may be performed just to rule out cervical cancer or anything like that. And then a glucose screening should also be performed. So due date estimation. You may hear this called a couple different things. I feel like most commonly it's just the estimated date of delivery, or EDD. You'll hear some people say estimated date of confinement, EDC, or some people will just shorten it to due date. So with that, we have Nagel's rule, which is what we use a lot of times to determine that estimated delivery date. And so what you're doing there is you're taking the date, the first day of the last menstrual period. From that date, you will subtract 3 months. So to use the example we've got on the PowerPoint, we're taking the date of August 8th is the first day of the last menstrual period. You'll subtract 3 months from there, so that puts us into May, specifically May 8th. And then from that date, you will add 7 days. So May 8th with 7 days added to that puts us at May 15th. So that would be the estimated date of delivery. Another thing that you may see is a gestational wheel. So it takes a little bit of the math out of it for you. Basically, there's months laid out around that wheel, and you'll line the arrows up on the date of the last menstrual period, and then with that wheel it will give you the estimated date of delivery. Additionally, ultrasound may also be used to calculate the most accurate due date. Subsequent prenatal visits. So what we're about to go over is typically used in your normal pregnancies. So if you've got a high-risk pregnancy or a pregnancy that's had some complications or issues along with it, it may not necessarily fit these guidelines to a T. So within a normal pregnancy, the patient's going to be seen every 4 weeks for up to 28 weeks. At that 29-week mark, they're going to be seen every 2 weeks. So from 29 weeks to 36 weeks, they're being seen every 2 weeks. And then they will be seen every week from week 37 up until the birth. At each visit, weight, blood pressure, urine protein, and glucose, and then fetal heart rate checks are done. The woman is asked about any of the dangerous signs of pregnancy at each of the visits. She'll also be asked about fetal movement, contractions, bleeding, and then membrane rupture. Usually the pelvic exam is not repeated until closer to the time of delivery. Each visit, the practitioner may measure the fundal height. This just kind of helps to make sure that the fetus is progressing as expected. The woman undergoes screening at particular times during the pregnancy. So, for instance, between 15 to 20 weeks of gestation, a maternal serum alpha-fetoprotein should be drawn. You may hear that shortened to MSAFP. And then between 24 and 28 weeks, all women should be screened for gestational diabetes. At 28 weeks, a woman who is determined to be Rh negative should be screened for antibodies and given anti-D immunoglobulin, or RhoGAM, if indicated. If not, they can have some blood compatibility issues if the mother's negative but the child is positive. If the baby is positive, the mother is given another RhoGAM shot after delivery. At 35 to 37 weeks, women should be screened for group B streptococcus. If positive, they will be given antibodies during delivery to keep the baby from getting infection coming through the birth canal. So next we'll talk about the assessment of fetal well-being. So fetal kit counts are what we have our pregnant mothers do. It can be done pretty much anywhere, at home, at work, on the run, whatever. Usually the woman will not feel the fetus move until about weeks 16 to 20. The practitioner informs the woman to monitor the baby's movements on a daily basis. She should choose a time of day in which she can relax and count the baby's movements. Each kick or position change should count as one movement. The woman should keep track of when the first movement starts, then continue counting until she counts 10 movements. Normally, the fetus should move at least 10 times in 2 hours. It can be affected by the time of day or other things. If it takes longer than 2 hours or the woman cannot feel her baby move at all, she should notify the healthcare provider. Excuse me. Ultrasound. It is used to assess gestational age, observe the fetus, and diagnose complications of pregnancy. It uses high-frequency sound waves to visualize the fetal and maternal structures. The fetus can first be visualized about 6 weeks gestation using the transvaginal approach. There's 2 types of ultrasound performed. The transabdominal, which the sonographer places the transducer on the abdomen to visualize the pregnancy. The woman may be recommended to have a full bladder, especially early in the pregnancy, to better visualize the fetus. A small wedge or pillow is placed under one hip to prevent supine hypotensive syndrome. A special gel will be placed on the woman's abdomen. And then there's also transvaginal, which the sonographer uses a specialized probe inside the vagina. It provides a clearer image because the probe is very close to where the fetal and uterine structures are. This is the approach used in earlier pregnancies. The woman is placed in the lithotomy position and then draped for privacy. The probe is covered with a sheath or a condom and is introduced into the vagina. Maternal serum alpha-fetoprotein screening. So alpha-fetoprotein is a protein manufactured by the fetus. The woman normally contains small amounts of the protein during pregnancy, measured at 16 to 20 weeks gestation. The main reason physicians recommend screening is to detect neural tube defects such as anencephaly or spina bifida. Even when results are abnormal, approximately 90% of the time the woman will deliver a healthy baby. Usually with abnormal results, a practitioner will schedule additional diagnostic testing with ultrasound and/or amniocentesis. This can be a very emotional time for the parents and the family until the results are confirmed. So we do want to kind of keep that in mind anytime this type of news is delivered. So another screening tool that we do is the triple marker or the multiple marker screening. This measures levels of 2 other hormones in conjunction with the MSA-FP. And so when testing that in conjunction with the MSA-FP, it does increase the sensitivity to the test. So hopefully we get more accurate results with that. So along with the MSA-FP, HCG, and the unconjugated estradiol levels are measured. A low MSA-FP with a low estradiol and an elevated HCG suggests that the baby has Down syndrome. Whereas if you have low levels of all 3, it suggests that the baby may have trisomy 18, which is a more severe and less common chromosomal defect. So another test that can be done is an amniocentesis. It's a diagnostic procedure where a sterile needle is inserted into the amniotic sac, and then a small amount of fluid is aspirated for testing. It's usually performed between 15 to 20 weeks of gestation. Most practitioners will not perform this test before 12 weeks because of the increased risk of complications. Second trimester testing is usually done to detect any suspected anomalies. Third trimester testing is usually done to determine fetal lung maturity. An invasive procedure that carries a small risk of spontaneous abortion, injury to the fetus, and chorioamnionitis, which is infection of the fetal membrane. The woman must give informed consent. It's practically painless. And then before the procedure begins, the practitioner must use ultrasound to locate a pocket of amniotic fluid to insert the needle into. After locating the pocket, the site is cleaned and prepped and a sterile drape is placed over the area. Next, the practitioner inserts a 20 to 22 gauge spinal needle into the site. The first half ml of fluid is discarded to avoid contamination of the specimen with maternal cells. Then 20 mL of fluid is withdrawn for sampling. The fetal heart rate is monitored by ultrasound closely during this test. The results are usually available in 2 to 3 weeks and are highly accurate. The woman remains on bed rest the rest of the day of the procedure, and then vital signs are monitored closely, especially temperature for infection. Leaking of fluids from the site or vagina, and then vaginal bleeding, cramping, or contractions are also watched for. Women who are RH negative should receive RhoGAM after this procedure. So another test that can be done is the chorionic villus sampling, or CVS. It's a newer procedure that can provide chromosomal studies for fetal cells, similar to an amniocentesis. Indications for CVS are the same as it is for amniocentesis. It can be done earlier in the pregnancy than amniocentesis can, which allows decisions about elective abortions to be made sooner in the pregnancy. It's typically performed around the 8 to 12 weeks of gestation. And just before the procedure, an ultrasound confirms fetal well-being, the location of the placenta, and gestational age. The woman is placed in the lithotomy position in stirrups, and the practitioner cleans the vagina and the cervix with antiseptic. Using ultrasound guidance, the practitioner inserts a small catheter into the woman's vagina and through the cervix. Placental tissue is then extracted into the syringe to obtain fetal cells for chromosomal analysis. Sometimes the practitioner uses a transabdominal approach with the needle, similar to the amniocentesis. This also gives faster results than the amniocentesis as well. Indications for amniocentesis and CVS sampling: advanced maternal age is generally accepted as older than 35 years. Previous offspring with chromosomal anomalies, history of recurrent pregnancy loss, ultrasound diagnosis of fetal anomalies, abnormal MSAFP triple marker screen or multi-marker screen, previous offspring with neural tube defects. If both parents are known carriers of a recessive genetic trait like cystic fibrosis, sickle cell, or Tay-Sachs disease. So 2 other tests that we can do during pregnancy are going to be the non-stress test and the contraction stress test. So we'll start with non-stress test. It's a non-invasive way to monitor fetal well-being. There's no special preparation for the test. A fetal heart rate monitor is placed on the woman's abdomen. She may be given a handheld marker to hold and record every time the fetus moves. The nurse or practitioner evaluates the fetal monitor after the woman has been on it for 20 minutes. Generally, if there has been at least 2 accelerations of the heart rate above baseline, the accelerations must be at least 15 beats per minute above baseline and last for at least 15 seconds to be considered. This is considered reactive, and this is good. However, if there are no accelerations or less than 2 occur within 20 minutes, the results are non-reactive. In this case, the monitoring would continue for another 20 minutes in hopes of obtaining a reactive non-stress test. This is because the fetal sleep cycle lasts approximately 20 minutes. The fetus can be stimulated by movement, eating, etc. So the contraction stress test, when the uterine contractions occur, it causes a momentary reduction of uteroplacental blood flow, which stresses the fetus. A contraction stress test monitors the fetus's response to contractions to determine his or her well-being. The woman is placed on the EFM. There are 3 ways to obtain uterine contractions. The easiest way is if the woman is having spontaneous contractions. There can be induced uterine contractions through nipple stimulation, and then IV Pitocin can also create those uterine contractions. The goal is to have 3 contractions of at least 40-second duration within a 10-minute period. After that, the practitioner reviews the fetal monitor strip to determine the reaction of the fetus to the stress of the contractions. If there are no late decelerations with the contractions, the CST is negative, which is good. Biophysical profile uses a combination of factors to determine fetal well-being. 5 variables are measured. NST measures fetal heart rate, acceleration. Ultrasound measures breathing, body movements, tone, and amniotic fluid. Each variable receives a score of 0, abnormal, absent, or insufficient, to 2, which is normal or present, for a max score of 10. A score of 8 to 10 indicates fetal well-being. A score of 6 correlates with possible fetal asphyxia, oxygen deprivation, whereas a score of 4 indicates probable fetal asphyxia. 0 to 2 are omnious and require immediate delivery of the fetus. The danger signs of pregnancy. Anytime we've got fever or severe vomiting, headache unrelieved by Tylenol or other relief measures, blurred vision or spots before the eyes, pain in the epigastric region, sudden weight gain or sudden onset of edema in the hands and face, vaginal bleeding, painful urination, sudden gush or constant uncontrollable leakage of fluid from the vagina, decreased fetal movement, signs of preterm labor, which would be uterine contractions, lower, dull backache, pelvic pressure, menstrual-like cramps, increased vaginal discharge, a feeling that something just isn't right. And that is it.